So welcome to the first ever IOCS MasterClass educational seminar series. Today, we welcome our first speaker, Dr. David Huang, who really doesn't need any introduction. So he is the co-inventor of the OCT technology. His 1990 science paper, which is seminar, created a new field of ophthalmic research. He is an early pioneer and early proponent of OCT angiography, again changing the playing ground for ophthalmology. Together, OCT and OCTA have saved the Medicare taxpayer billions of dollars, more than 10 times the federal investment. To honor his achievement, Dr. Huang is a recipient of the Lasker-Dickbacke Clinical Medical Research Award and the National Medal of Technology and Innovation. So without further ado, let's welcome Dr. Huang.
Thank you, Siyu. And I want to thank Dr. Amani Fawzi, who has the idea of having webinars to get into the basics of ocular circulation, including imaging technologies. And also Dr. Siyu Chen, who's organizing this seminar. So I'm a co-founder of the International Ocular Circulation Society, or IOCS, and this is starting back in 2015 or so. So IOCS, of course, was started to promote research in ocular circulation, but really personally, I co-founded the society so that we can promote OCT's extension into ocular circulation research, which include Doppler OCT and OCT angiography. And I'm going to talk about the kind of my journey in this area. I do have financial interest in OCT and OCT angiography technologies, as stated on the screen. So of course, OCT got a lot of attention in 2023 with the co-inventors getting the Lasker Award and the National Medal of Technology Innovation. And so I'll start with OCT a little bit as a background. So this started with Professor Fujimoto's idea of using light to measure the time of flight of light, starting with femtosecond lasers in tissue. And then when I got started in this area back in 1990, using Michelson interferometer with short coherence length light source to measure tissue reflections or backscattering down to the femtosecond range or micrometer range. And this was the initial OCT system in Professor Fujimoto's lab. I was showing my father this setup. It's in a tiny corner of a table that was dominated by a femtosecond laser. And the initial system was amazingly slow. It takes more than a second to get an axial scan. But that was just the first step, of course. It got much faster later. But even in the beginning, I was able to see subtle signals inside the retina, which gave me the idea that this could be the basis of an imaging technology, and led to the original paper on OCT in 1991. And of course, OCT has become really useful in ophthalmology because it uses invisible light that doesn't dazzle the patient. It only takes seconds to do a scan. It's very economical. The technology turned out to be relatively easy to implement for high performance eye imaging. And it generates digital files that's amenable to computer and artificial intelligence analysis. And we all know this, and that's why it's been so useful. It's able to, it's really the only technology that can get you micrometer resolution images in the eye. And it's now indispensable in managing the leading diseases, leading causes of blindness in ophthalmology, including age-related macular degeneration, diabetic retinopathy, and glaucoma. And just on the management of wet AMD with anti-VEGF injection, OCT has really saved countless patients from blindness. And this is one of the really major imaging application and drug in ophthalmology, with 2.5 million injections per year in the US and 40 million OCT procedures. So this has become really dominant in ophthalmology. And behind the advance of OCT is this steady increase in its performance, specifically the speed of OCT imaging, the axial scan rate. It's been doubling about every 2.5 years. And this has driven the improvement in clinical applications, and not just making it faster to do a scan, but really allowing new qualitative changes in the way it's practiced and brand new capabilities. And these include extending structural OCT to 3D volumetric imaging over ever wider field of view and higher resolution. But really, what excited me in the past 15 years or so has been the ability to obtain new contrast, such as Doppler OCT measurement of blood flow and OCT angiography to look at the ocular circulation down to the capillary level. And that's what I'm going to talk about in terms of our research group development in these two areas. So back in about 2009 or so, long time ago, I started thinking about getting into the area of OCT blood flow measurement with Doppler. And this was inspired by several pioneers. Specifically, I want to credit Stuart Nelson for really pioneering back in 1995 flow velocity measurement with Doppler, and then Jill Izod and Zhongping Chen, who are my good friends, who really excited me about this area. And I think it's a visit to Zhongping Chen in Irvine that got me thinking about working on this myself. And to get Doppler measurement of blood flow velocity, you need both the Doppler shift measurement and also the Doppler angle. This is the angle alpha here on this drawing. So those are the two basic measurements. So the initial contribution that we made was developing a way to measure total retinal blood flow as a biomarker for eye diseases and perhaps systemic diseases. And this was done with a double circular scan that transects all retinal branch vessels several times a second and provide Doppler OCT cross sections in two circles. And from these two circles, you can get the relative axial position of the blood vessels and calculate the Doppler angle. And you can sum up all the retinal arteries or veins to get the total retinal blood flow. We chose a vein in the early days because the speed was limited. And then you can measure over several cardiac cycles to get the average blood flow. The reproducibility was about 8 to 10% using this technique, which is fair. And using this technique, many people have investigated diabetic retinopathy, and the major findings were that there's reduced flow and velocity in proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, and diabetic macular edema. And these will be exacerbated by laser pan-retinal photocoagulation, which of course causes atrophy of a large part of the retina. It's also been used to investigate sickle cell anemia, in which a low hematocrit leads to lower oxygen content in the blood, which necessitate higher flow to carry the oxygen to the body. And that's really been very well documented by Dr. Shahidi's group. And this was also used to look into autoregulation of retinal blood flow, which responds to flicker stimulation, hypercapnia, which means breathing carbon dioxide, hypocapnia, which means hyperventilating, and also hyperoxia, or breathing air with high oxygen content. So this demonstrated a principle that all these neurovascular coupling or autoregulation phenomena can be quantified as biomarkers. A limitation of this technique using a single OCT beam and a single Doppler angle is that it's not always possible to measure the total retinal blood flow. Generally, we found about 30% of the time, there's a sufficient number of vessels that has low Doppler angle or near perpendicular beam incidence that a valid measurement really could not be made. And that has been really something that has limited the more wider clinical application. So to get around that, of course, in this field, I have so many clever people. We have people coming up with clever devices. Patterson was a graduate student in Andrew Rollins' lab that worked with us to develop an early dual beam Doppler system. And Peterson et al. Also tried that. And this works. Of course, this requires more careful alignment of the two beam plane with the direction of blood flow. The Vienna group has an even more elaborate system with 3 beams, which ensures robust measurement of blood flow. I guess the only drawback is that it's very complicated when you get to having 3 beams. The ultimate, I think, is on-fast OCT, pioneered by Professor Fujimoto's group at MIT, that look at the retinal veins and arteries en face, right where they enter the eye. And this way, you don't need to measure an angle at all. Basically, you're measuring the component that's parallel with the OCT beam. And this can give you higher repeatability of 4 to 6%. And I think this might really have good future applications because it's simpler, but it requires higher speed. Overall, I think there is a limitation in measuring ocular blood flow in that there's quite a bit of population variation, even among the healthy people, generally around 20% or so, no matter what technique you use. And that may just be because there's a large real variation in terms of physiologic states between people and their ocular physiology. So overall, we found that total retinal blood flow it's difficult to apply as a diagnostic biomarker because it's just one number and there's relatively large population variation. And there are technical challenges with measuring the Doppler angle. Although I think the en-phase technique with higher speed now becoming easier to achieve might have future applications. So at around the time I moved to OHSU, which is 2010, I started thinking about another area, which is OCT angiography. And the partner I found then to work on this is Dr. Yali, who has, of course, made great progress in this area. And I like to think of OCT angiography as an extension of OCT into the fourth dimension of time by repeatedly measuring OCT at the same location so that you can detect a change in signal from motion. And this is a video demonstration showing that if you subtract two video frames, you accentuate, you remove the static structure and you accentuate the moving tennis balls, which you can think of as red blood cells, and also the projection, the shadow on the wall, which correspond to the projection artifacts that we see. And so this analysis of signal variation over time to provide angiographic signal was pioneered by Dr. Yoshi Yasuno in Japan as early as 2006. And Dr. Ricky Huang, of course, has made, his group has made many contributions to this area as early as 2007. And Dr. Yali was a graduate student with Ricky Huang when I came to OHSU in 2010. Actually, I was thinking of working with Ricky on this area, but then he almost immediately moved to University of Washington, causing us to develop our own OCT angiography research program, which was actually helpful. And Ben Vakash was also a big influence on me. I visited him around 2009, and he explained to me how both phase and amplitude decorrelation in OCT angiography are related to the same speckle phenomenon, and that really led me into thinking on how to optimize it and develop my own algorithm. So these early investigations were not ready for clinical application because the imaging areas were very small, and the algorithms were not very efficient for producing high quality angiograms down to the capillary level. So to introduce this technology into the clinic, you need very efficient algorithm and high-speed OCT system. and Dr. Ricky Huang's group and our research group, both at OHSU, developed the algorithms that became commercially, clinically available through Zeiss and OptiView around 2014 or so. And that was the time when I was thinking of co-founding the International Ocular Circulation Society, so we can have a venue to talk about this new technology and invite in scientists who really know ocular circulation, so can tell us what we're actually seeing with these imaging technologies. So our contribution initially was the development of split spectrum amplitude decorrelation angiography, or SADA. And this is to split each OCT image into spectral components with narrower spectral window. And with a narrow spectrum, what happens is that the speckle grain becomes larger. And I think there's a optical size of the speckle grain where it's on the scale of the blood vessels you're measuring, and actually up to the distance between vessels or plexuses. And so by splitting the spectrum, you can get more image pairs on which to compute decorrelation. And when you recombine them, you get you're able to measure flow signal with higher signal to noise ratio. It's equivalent to increasing the number of image frames without an increase in scan time. So it's very efficient. And Dr. Simon Gao, Yali, and me first published this in 2015, showing that you can achieve higher signal to noise ratio and measure vessels more accurately. So now that we have an efficient algorithm, we could apply it to the clinic. The initial application was on choroidal neovascularization and visualizing it on FOS, which was also relatively new back then for OCT. And that's when we joined Dr. Bruno Lombroso's Congress in Rome, and it's the biggest annual forum for looking at on-FOS OCT, and OCT angiography very quickly became kind of the biggest hit there. And with OCT angiography, unlike OCT, on-FOS was just from the start is essential for visualizing pathology. For example, the neovascular membrane and the choriocapillaris flow defect. And you can see that OCT angiography have different contrasts from fluorescein and regular structural OCT, in that it can see capillaries with high contrast, and you can tell which layers these capillaries are in. So early on, we carried out quite a bit of investigation on what the OCT angiography signal or decorrelation means. And we found that it really depended on a lot of factors, including the vessel caliber, or relative to the beam spot size. It was dependent on the reflectance signal strength, and it's very sensitive to beam defocus. And its relationship with the speed of blood flow is highly nonlinear. It saturates very quickly. So it's relatively difficult to quantify blood flow velocity or blood flow using the correlation. And we're still working on that. So we pretty quickly move on to just looking at the capillary structures and not paying as much attention to quantifying flow velocity with OCT angiography. There's also a lot of artifacts associated with OCT angiography, the most prominent being bulk motion artifact. And there are solutions to filtering it out with orthogonal registration with the MIT and Erlangen group. Tracking can help remove it. And there's a successive generation of OCT angiography improving the image definition, which greatly improve the visualization of capillaries. And a wider field of view are becoming available on several commercial clinical systems by single shot, better optics for single shot imaging and montaging several images. This, I think, is the largest commercial system we have now with single shot 130-degree eye angle and 200 degrees in montage. You can see the vortex vein ampulla with this system from Interlight, which qualify it as ultra high resolution. So it's very exciting that these are already in clinical use, and not in the United States yet, but I hope it will be soon. Another important artifact in OCT angiography was the projection artifact. And Dr. Yali, our clinical collaborators, and really about 3 generations of postdoctoral fellows and graduate students have worked on this now in the algorithm and clinical applications. So the projection artifact can be seen on these cross sections as vertical streaks. So blood vessels in the inner retina would project through scattering and shadowing the change in the OCT beam down to structures below, including the RPE, which doesn't normally have flow. And this can be seen on FOS as duplication of superficial vascular patterns onto deeper layers. Fortunately, you can remove these artifacts through algorithmic means in software after you acquire the images. And there have been several generations of these algorithms, and they are quite effective. And with this projection resolve OCTA, you can see 4 plexuses, 2 in the superficial vascular complex and 2 in the deep vascular complex. And by looking at these plexuses separately, you can better diagnose diseases. So this is a projection resolve OCT angiography of choriocapillaries showing that removing the artifact give you a pattern that's closer to the true pattern of choriocapillaries. And in the fovea, it shows that the plexuses converge at the edge of the foveal avascular zone. So there's really just one FAZ size measurement that you can make. So I don't think we should be measuring separate superficial and deep FAZ areas, as some people do. And you can generally categorize diseases in ocular circulation by their the plexuses they affect. Optic nerve diseases generally affect the superficial vascular complex. Outer retinal diseases affect the deep vascular complex, and retinal vascular diseases affect all plexuses, and neovascularization can be also classified by their depth. So glaucoma is an optic neuropathy, so it affects the superficial vascular complex in the macula, and the nerve fibrillary plexus, also known as the radioperipapillary capillaries. And if you focus on that, you increase the diagnostic sensitivity for detecting glaucomatous damage. And outer retinal diseases such as retinitis pigmentosa mostly affect the deep capillary plexus, as you can see on the lower right. And diabetic retinopathy, of course, affect all three plexuses and have a wide variety of manifestations from non-perfusion to microaneurysm to dilated capillaries. And we have shown that by looking at the plexuses separately, you can improve the visualization of non-perfusion, and they're more sensitive measurement of diabetic change, even among people with no clinically visible diabetic retinopathy. And the foveal avascular zone is a basic measurement that you can make on OCT angiography. And I think it is a good biomarker for measuring progression in the same person. But to compare with the normative data, it's difficult to diagnose disease that way because there's a wide range of variation among the healthy population. But by looking at the donut around it, the para-FAZ vessel density, you can detect disease or foveal ischemia with much higher sensitivity. And of course, OCT is very good at picking up neovascularization that extends from the retina into the vitreous, even at early stages. And I think that's going to be a major application now that wide field OCT angiography is becoming, starting to be more widely available. And CMV, again, is a major application of OCT and now OCT angiography. With OCT angiography, it's easy to distinguish between neovascularization below and above the RPE, and these roughly correspond to occult and classic lesions on fluorescein. And we often see now something called non-exudative CMV in clinical practice, where we see no leakage on fluorescein angiography, no fluid accumulation on structural OCT, but neovascular membrane on OCT angiography. These are type 1 lesions under the RPE. They tend to grow over time and begin to leak fluid at some point. There's a very high rate of progression to exudation. In our study published in 2019, the cut hazard ratio was 18. And this is a common pattern where you first detect a small lesion, it grows over time. And then when exudation starts and anti-VEGF therapy starts, the rate of growth tend to slow down because of the anti-VEGF effect. Some lesions grow very slowly and do not progress to exudation. And these neovascularization might actually be helping to supply the retina. So I think this is a major application for OCT angiography to find neovascularization early in AMD so that we can follow them. These lesions, the non-exudative lesions, should probably be monitored monthly in the first 6 months after detection. So OCT angiography started around 2014 or 2015, and by now there's already 3 generations of systems. So the first generation have speed around 60, 70, or 80 kilohertz axial scan repetition rate. The newer systems have speed above 100 kilohertz, as fast as 400 kilohertz in some demonstration systems. Of course, these are not FDA cleared yet in the United States, but the higher speeds will allow higher definition measurements and a wider field of view and make the technology more clinically useful. And in the US, it's actually very important for the clinical use of a technology to have a separate current procedural terminology or CPT code for reimbursement reasons. And I was very happy to see that there was an announcement to implement 2025 in 2025 a separate CPT code for OCT angiography. And this is for retinal OCT angiography. I actually don't know, or I don't know if anyone knows whether it will include glaucoma or corneal applications. But the new code will carry twice the work RVU or physician reimbursement compared to now conventional retinal OCT. So I think this will allow retinal physicians to utilize OCT angiography a lot more and will lead to, I think, much faster improvement in the clinical spread of use of this technology, and also incentivize the improvement in software that manufacturers provide, and in the long run, evolution of better hardware. So this is a great development, regulatory reimbursement development that will drive the use of this technology. So to recap the milestones for clinical OCT angiography, first product was launched in 2014 and 2015. And at that time, the CPT code was shared with conventional structural OCT, so it's paid the same. And so only really early adopters will want to use it in the clinic. And of course, this will produce a lot of research papers and conference presentations and evidence that this is useful. So now that finally we have a specific CPT code and a higher work RVU assignment in 2025, and I predict that this will lead to wide adoption of OCT angiography because it'll be paying more than OCT, and the reimbursement will drive utilization and the purchasing of equipment. That is to say, I recognize medicine is also a commercial enterprise. So OCT angiography is really a paradigm change in angiography in ophthalmology that occurred in the past decade that will allow us to stop doing injections for fluorescein angiography It's faster than dye-based angiography because you don't have to wait for transit. And it's cheaper. It's better in some ways, and it's getting better all the time. And I think it will be used at every visit for some diseases like AMD and diabetic retinopathy for screening and monitoring. And it'll be used a lot more than fluorescein angiography ever was. So now OCT angiography sort of made it. It's like a baby that's grown up and out of the house. Now I'm thinking about this orphan Doppler OCT again, that I haven't really paid much attention since about 10 years ago. And the new impetus is to look at pulsatility. And there have been development that I follow in the literature. Bortak et al. Look at Doppler OCT for retinal venous pulsation measurement. There's also work in looking at arterial pulsation, and this waveform is fairly repeatable. It can be used to measure the upstroke time, and that's found to be useful in looking at the delayed rise of systolic rise in velocity in a couple of papers, specifically in Takayasu's arteritis with secondary aortic regurgitation. And we've been working on a system that can control the Doppler angle, and we can adjust it to more reliably measure flow. And this is some of our very recent data showing we can control the beam position and the pupil and produce Doppler OCT with good signal consistently. And we look at measuring the pulsatile waveform and deriving quantitative measurements. And these measurements include the acceleration and deceleration times, or the upstroke time and diastolic relaxation time. And we found these are actually can be quite repeatable, especially the acceleration time, better than 5% repeatability. The resistive index, which is related to the ratio of minimum and maximum flow, is also quite repeatable. So I think this has the making of something that can be used reliably to measure systemic hemodynamics and the cardiovascular system. And it's mainly of interest, actually, I think, outside of the eye in systemic diseases, such as aortic valve stenosis and regurgitation, arterial hypertension, and microvascular diseases in the cardiovascular system and cerebral vascular system. So this is of renewed interest in our research group. So this concludes my talk. I'd like to acknowledge support from our NIH grants, foundations, and our commercial partners who provide material support. This is our research group, the Center for Ophthalmic Optics and Lasers, which has now grown over the years to be quite large. And please visit us at coolab.net. Thanks. We're open for discussion.
Excellent talk. Let's thank our speaker, Dr. Huang, and we'll now have panel discussion. So you can put your questions into the chat box and we'll read to the speaker. And meanwhile, I think we'll start with some questions as the audience type in. So like it's a full circle. We start with Doppler, then go to the OCTA, then we think Doppler might be a relevant again in the near future. So what do you think that takes us in the next few years as technology development?
So can you say again? I was reading this question from Kumar.
Ah, okay, so basically, what do you think the technology will be or the direction in the next few years of ocular blood flow imaging?
I think the biggest change will be the wider field of view. Probably would be the first thing that would occur, would become, they've already been demonstrated, would become more available, especially in the US where we still have don't have access to the latest. There will be more effort to get regulatory approval from the FDA to market it in the United States. And then the development of quantitative biomarkers that can be used in clinical trials. Again, they've already been demonstrated, but the adoption by clinical trials and regulatory recognition and approval will take some time. And then once people look into quantification more, I think there will be more quantitative biomarkers and normative databases that will be made available. And to support that, the spatial and time resolution of OCT angiography or Doppler technology will need to improve. And I think that will follow. So fairly predictable, I think. There are a lot of things that's already been demonstrated in the laboratory that will gradually become introduced clinically with a clinical need being recognized and regulatory allowance.
So Kumar asked how the pulsatility will be helpful for OCTA and how would you limit bulk motion in OCTA?
Well, the question is very perceptive. OCTA, of course, can be used to visualize and measure pulsatility. And that once we are able to measure the change in blood flow and flow velocity over the cardiac cycle, if you average over them or compensate for the pulsation, you can measure flow index or quantify flow with OCT angiography better. And once you go down that route, you find that, of course, bulk motion is a big challenge because that affects the OCTA signal. So we will have to develop ways to subtract it out. And there are algorithms that can do that. But the clinical adoption will be challenging in that to look at both the OCT angiography over the larger area and being able to capture the cardiac pulsation means you have to capture both space and time, large range of space and time, which will be a longer scan. So high-speed systems and algorithm for tracking and registration will be more demanding. So I think it's relatively difficult to get these type of measurements, and I'm not quite sure they will become clinically useful for a while yet, but it's definitely a very interesting area for research, and I'm very interested in that. There's someone interested in discussing it, I think.
We have some more questions. So Dr. K asks, as imaging depth in the choroid and sclera remains a challenge, are there specific advancements in OCT and OCTA that might significantly improve penetration without compromising resolution?
Well, I think we all recognize by now that using a slightly longer wavelength, a 10-15 nanometer wavelength, can improve penetration into the choroid and even scleral blood flow over the spectral domain at 800 nanometer or so. And the resolution you can obtain at 10-15 nanometer, of course, is more limited to about 5 micron axial resolution or 6 microns. But that's still fairly good. So that's as swept source OCT become more available, that's going to make choroidal measurements more of a common, choriocapillaris measurement more of a common thing. The choroid also, the larger choroidal vessels are very difficult because they're deeper and the flow is very fast beyond the dynamic range of OCTA systems on the market now. In fact, they produce a void in OCT signal, and that's how they're often visualized, is by lower reflectance because of the fringe washout phenomenon. And that's one reason I don't like the term flow void, because it's get confused with this structural void that you see from fringe washout. But I think as you go into the megahertz range, and I think OCT speed will get to the megahertz range in in 5 years or so. The fringe washout would be more limited, and we'll be able to see choroidal vessels or see the flow signal there better. So improvement in longer wavelength and higher speed will help us see the choriocapillaries and large choroidal vessels.
Okay, and
yes, I have a question. So first of all, thank you so much for your wonderful talk to talk about OCT from time domain OCT and then the future of OCT. So in regards to OCT angiography, do you think the clinician will more focus on qualitative analysis or quantitative analysis? If we more focus on quantitative analysis, so how can we, what do you think, how could we tackle the issue on different OCT device, different OCTA device, because they have their own algorithm? So the measurement, I believe, is not interchangeable. So how should we target these issues? What's your thoughts or advice on this?
Yeah, that's a very good question. The OCTA algorithms on the manufacturers often are not really clearly defined, and that you can measure the correlation or variance based on amplitude or phase or both, and they have somewhat different characteristics in terms of dependence on reflectance, bulk motion, projection, and so forth. So it's there could be fundamental differences between the OCTA you obtain from different machines. And the definition of things like vessel density will also vary. So I think in order to perform diagnosis, it's more important with OCTA to have normative data that you can compare to, and validation of diagnostic criteria for a decrease in vessel density or non-perfusion areas, all that would need to be I think you have to validate each machine in both normal patients and disease patients. So yeah, clinical validation is for each machine is probably going to be necessary. It's harder for them to become interchangeable. We already have some difficulty with that with structural OCT because they have different resolutions and signal to noise ratio. But with OCT angiography, these issues will actually make even bigger differences. Yeah, generally these machines are not going to be interchangeable. Even between generations from the same company, the algorithm can improve and change a lot, and you have to get reacquainted with how they behave in patients.
Mario, I think you have a question, right?
Yes, I wanted to ask, what are the, bigger mistake that a young researcher that wants to use OCTA in his research should avoid?
I think this OCTA research it deals with a more complex technology and also physiology and anatomy. So you have to learn about the imaging technology and the structure of the retinal circulation first in order to ask the right questions. I think in my talk, I talked about some pitfalls. One is not recognizing the projection artifact. There's a lot of study of deeper retinal circulations or choroidal circulation that does not take into account projection artifact, and those are difficult to really interpret the results when they could be due to artifacts. So learning about the artifacts and how to compensate for them is it's a burden for new researchers in this area. And also dependence on signal strength is another one. And for some type of measurements, bulk motion artifacts. So these are all technical, and it probably takes longer for someone to learn about OCT angiography technology enough so that they can conduct clinical research that are more robust and interpretable. So that's why we need the International Ocular Circulation Society to spread this knowledge.
Totally agree, Dr. Huang.
Yeah, so maybe I can ask a last question. It's about wide field and the new trend of home OCT imaging. So Dr. Huang, do you think that OCTA will make it as a home OCTA device, or will the costs be simply too much and the focus in the near future will be more on wide field, which apparently using megahertz technology will be quite a challenge in terms of costs and availability, I guess.
Oh, well, home OCT, I think generally the low-speed spectral domain OCT system where cameras are relatively cheap, and they're not, I don't think they will support OCT angiography for a while, although it's difficult to predict the future. Eventually things become cheaper as technology become more widely available. So I would think there would just be a lag until you can have home OCT angiography. But not right now. It's too expensive for home use. And I'm very excited about megahertz speed OCT and OCT angiography. And we're already doing that in the laboratory. And I'm sure, again, the technology is too expensive now. But I think it will not take long for them to become economical enough for wider spread use, especially if the reimbursement codes allow it. That's why I'm so excited about the recent new CPT code, because that would support more advanced technology. Reimbursement policy, which is a government policy in the United States, really actually control a lot of technology development in the companies. So even small changes can have big effects in just some agency change in coding, which is often outside of our control. And I want to thank Dr. Rosenfeld, who has worked, I think, for several years and advocating for this new CPT code. Theo Rosenfeld. I'm sure other people have helped as well, but that's going to help all of us a lot. I know some of you are in Asia or Europe. This probably is a minor matter, but it'll spread there because US is still the biggest market.
Wonderful talk and inspiring discussion. Unfortunately, I have at the end of the allotted time, and unfortunately, we cannot answer all the questions. But thank you again for joining us, and let's thank Dr. Huang for his presentation. And we'll see you in 2 months' time. Bye-bye.
Thank you so much, Dr. Huang. Bye-bye,
Thank you.
everyone.
Bye-bye.